And I do have 11 o'clock, so we'll go ahead and get started. You've joined actually our virtual version of the Critical Access Hospital Convening meeting that we conduct twice a year. And our next meeting we have tentatively scheduled for October 9th. And I think if we all aren't released by then, we may be a little bit crazy, but we'll hang in there. I'm Becky Royer. I'm with Valiant Health Quality Solutions. And as always, I want to thank Allie Orwig, who supports the Zoom platform in the background and works at the Indiana Rural Health Association. The Critical Access Hospital Convening, as many of you know, is a partner conference that we hold, and those partners include ISDH State Office of Rural Health and Epidemiology Resource Center, the Hospital Association, the Rural Health Association, QSource, and Valiant Health Quality Solutions. Just want to take the time to really thank all of the critical access hospitals for all the tireless care and the switching of roles and just jumping in and doing what you need to do during this pandemic for our rural Hoosiers, and really appreciate our rural communities right now in our rural homes. All lines will be muted here in the beginning. We do encourage you to chat any questions in. I know that many of you have become a little more Zoom savvy over the pandemic experience, but please feel free to unmute your lines and chime in. We want to answer all the questions that you have. You can also chat Allie and she'll help unmute you too. Today's session will be recorded and we will send that link out later on, so please feel free to share it internally for those who could not attend. We appreciate everyone who completed the survey regarding the topics to be covered during our hour and a half today, which we will be covering COVID-19, and the ECHO team will be presenting, as well as sepsis and answering some of those key questions. The Critical Access Hospital Award the nominations will be extended due to the pandemic, so there'll be more information about that coming. We will be taking some time at the end of the meeting today to kind of do some networking among all of you, so feel free to share. We distributed some key questions that we would kind of like to hear a little bit about. However, if you have topics that you want covered or you have questions you would like to see covered, what you ask will take priority. So with that, I will turn it over to Becky Sanders, and she'll be presenting our first speakers for today. Becky?
Thanks, Becky. So today our first two speakers are Juan Carlos and Andrea from the IUPUI project. I've gotten to know them just a little bit over the past few weeks, and they've done a tremendous job of pulling together all kinds of speakers and talking about best practices through this public health emergency that we're all experiencing. So at this point, I'm going to go ahead and turn it over to them.
Great. Thank you so much, Becky. And I appreciate the introduction, but I also appreciate you and your expertise and your time that you've shared with us and our COVID ECHO. It's people like you that make this something so useful for our Hoosier community. So I appreciate that so much. Juan Carlos, do you want to do a quick intro before we get started?
Yeah, and just to kind of say from the get-go that we like to be interactive with ECHO, and so Andrea and I are going to tag team this presentation. We're very familiar with doing so, and I love that you, Becky, called out to folks to unmute themselves and chime in. I see that there's you can, if you have a question, you can put it in the chat box and we can call on you. I've gotten good at kind of monitoring the chat box too, or they can be fed to us. That's great. And just want to be able to show how we're using this tool to address a very recent and current issue that's emerged. Anyways, my name is Juan Carlos Venis. I'm a family physician, about 70% of my time seeing patients in Indianapolis in a community health center, strictly outpatient, and also help facilitate our LGBT health ECHO. I do a lot of work with the LGBT community and do gender affirming care for the transgender community. And then I also, in my 38% rest of my time, work at the medical school in medical student education and family medicine. And then also with programs like ECHO. I graduated from IU School of Medicine and did my residency at Ball Memorial Hospital in Muncie. So I was there for 3 years and almost stayed there. I really have a love for that area, and I have actually many patients that come from there to see me, anyways, I just have connections still to that area. And so I appreciate all the people up at, like South Blackford mentioned, and those areas around there. You all do really great work. So shout out to you guys. And yeah, that's me.
Thanks, Juan Carlos. So I'm Andrea Janota, and I work at the Fairbanks School of Public Health. I'm the interim director for the IUPUI ECHO Center, and we'll talk kind of more in depth about all of the programs that we have available. And I also oversee our Center for Public Health Practice. So we do more than just ECHO, but I have to say it's been an incredible tool to be able to respond to the epidemic, the pandemic. What am I saying? This pandemic situation. So I'll go ahead and just provide a little bit of background in terms of what Project ECHO is. So you hear the ECHO acronym, and that is Extension for Community Healthcare Outcomes. I promise you, never have to remember that again. But you'll probably hear us just call it ECHO for short. And to give you just a little bit of context really briefly, this model was created by Dr. Sanjeev Arora in New Mexico. He's a hepatologist, and his concern was that he had patients who were on incredibly long wait lists, and by the time that they were getting to him, they had more severe health outcomes than they really truly needed to. They had preventable health outcomes. New Mexico is incredibly rural. They have maybe 1 or 2 bigger urban areas, even more rural than Indiana. So he came up with this model to be able to spread knowledge. So his whole idea is moving knowledge, not people. And he uses Zoom and was able to, as a specialist, be a hub. So you kind of see our little hub and spoke image here. So with him and his team of ID docs and other specialists in Albuquerque, we're able at a medical setting at the University of New Mexico. So he was able to be this hub and speak to providers all over the state of New Mexico about hepatitis C treatment. So that's kind of where he started. Again, with that wait list and people needing to drive several hours to get to his office, it was hard to keep up with their care. He didn't have an established relationship with them. He really just saw that there was an issue that needed to be addressed. So he created this peer-to-peer and kind of all teach, all learn. So you see all those arrows going in all different directions. Of course, the hub might by title be the specialist, but they are learning from the community providers and from primary care providers just as much as those providers are learning from the specialists. It truly is an all teach, all learn model. And he started this in 2003. It grew pretty rapidly once people started hearing what it was that he was doing and what he was able to do. But in kind of a nutshell, if this image at the bottom here, ECHO is responding to the need that people have for specialty care for complex conditions in the face of not enough specialists, especially in rural or underserved communities. So ECHO is going to use that provider to provider, that peer-to-peer model to increase access to services, and patients are able to get the right care in the right place in the right time. And I just think that's so important that patients are able to meet with their medical providers in their home community. That's people that they know, it's people that they trust, and being able to save all those other resources in terms of time and gas money and all those things by being able to be treated in their own home community. So just to give a little visual, so we love telemedicine. We think that it serves such an important purpose, but just to kind of differentiate kind of how ECHO is a little bit different, you have this expert hub team that's talking with, you might hear us say spokes or community providers, people who are joining into the network, and they're able to then use their knowledge that they're learning in these sessions to reach all of their patients. So we're teaching comprehensive care, and it's this idea of force multiplication, which is actually a borrowed military term. But the idea is that the person at the very top knows what's happening at the very bottom, and the person at the very bottom knows what's happening at the top. That information is spread equally throughout, and you're able to force multiply the efforts and the response. So we have far too many little mottos and sayings in ECHO, but another is that we're not training, we're not treating patients, we're training providers. So in our echoes, we're doing case presentations. We really heavily rely on case-based learning, and we'll kind of get to do a little bit more of that soon. But the truth is that we care very much about that patient. We want that patient to get the right care that they need, but we're really looking at how do we train providers comprehensively. So if you tweaked one aspect, what would that change? How would you then, if you have another patient who's similar, but has slightly different scenarios, then how do you still make sure that that provider has the knowledge and the mastery of skills to apply what they're learning in every situation? And of course, the responsibility remains with the provider managing the patient. So there's not any part of like liability here. It's all de-identified. We never know who the patient is. So I said that ECHO started in New Mexico in 2003, and this is probably still an outdated snapshot that I took maybe a month ago, if even that. ECHO is operating in 32 different countries. People come to New Mexico or other super hubs that are around the world to learn about this model, to do an immersive training, and then to start their own programs. So we commit when you go through an ECHO training that you're going to be faithful to the model, which just means that you're going to use that case-based learning and you're going to provide evidence-based information. And then we track all of that. So when you guys hear us asking for attendance and things like that, like we're providing all that data back to New Mexico just so that they are able to show the impact of this model, which clearly it's really spread across the world. It's more of a movement at this point because the model is so flexible and adaptable, which is why it's been great for COVID-19. So here's, again, older slides pre-COVID. So here was a spread of the providers who were joining our existing ECHO programs. We have 5 that are clinically focused. We have a hepatitis C ECHO. We were the first to get to start ECHO in Indiana, and Indiana was the 38th state to sign on with ECHO. So we did that in 2018 and launched that program in January. Not too long after, we got Juan Carlos and his team to join with an LGBTQ+ ECHO, which is now in its 2nd year. We have an HIV ECHO, which is also in its 2nd year. So we're really excited to see these programs continue on, and people are welcome to join at any point. It's not something that like you have a window that you can only join, in January when it's the beginning of year, whatever. People are able to join all the time because we're doing those case-based learning. We're mastering skills all the time. Things are getting reiterated and reinforced. So people are always welcome to join ECHO. We have a cancer survivorship and prevention ECHO. And then one of our newer ECHOs is integrated pain management. So that's happening this Friday if you guys are interested. We do offer free continuing education for the ECHOs listed here. So we have the ability to offer CMEs through the Indiana University School of Medicine continuing education office. So we offer for physicians, pharmacists, nurses, social workers, and then non-physicians. And then we also are working with the Indiana Academy of Family Physicians to provide a credit for family physicians. What I don't have included here is CHES, so Certified Health Education Specialist. We now have credits for them as well. So we're really creating this as a very interdisciplinary practice. We're bringing people with all sorts of expertise coming together, and we'd like to acknowledge and provide some recognition of the training that you guys are receiving through ECHO with these continuing education credits. It's free. So that's really, really nice. And then something new that we just got to start is if you do one of those case presentations, you get an extra free hour of CME because we know putting together those case presentations is a little bit of extra work. So we want to acknowledge that effort as well. So that's to give you some insight. Juan Carlos, anything else you want to add about your experience with the LGBTQ ECHO?
Well, so just to throw out like the role. So this presentation today is more going to address how you can use the ECHO model to handle multiple things, but as well as how we've done it with COVID, which I'm going to talk about briefly. My role has been as kind of like a facilitator and facilitating the question and answers and trying to handle this mass of people. Our COVID-19 ECHO has been unique in terms of a beast because of the number of people participating you're about to hear about. But often in these ECHOs, you're having 25 participants or so. At least that's my experience with the LGBT ECHO. We see a lot of familiar faces. We build a sense of community. As a result, providers at like Butler have started to offer new services in student health that they didn't before, or more comprehensive services. And we've had health providers in Southern Indiana and in the Lafayette area really sign on and start taking care of patients with continuity and doing things that they would have maybe previously referred out for. So it's been really fulfilling to see that. And we're looking at continuing to have that impact and be a source because we really want to kind of work ourselves out of a job of needing the echoes to exist. For some things, we think that there'll probably always be reason for there to be an echo when there is that disparity in access to resources. But no, we can keep going.
Great, thank you, Juan Carlos. And I agree. I'd love to work ourselves out of a job in terms of being able to just have more access to specialty care. But other things that we see with ECHO is that community aspect, and people with some studies, and we can share the literature there, but you know, there's been studies that show that providers feel less isolated in their communities if maybe they are practicing somewhere that is a little bit more rural and they don't have as many people to interact with in terms of their healthcare team. So that's a really nice aspect, is that they have a community that they can come and talk about the challenges that they're seeing. There's also higher retention rates seen with providers who participate in ECHO. They're more likely to stay with their practice longer. And just the expansion of being able to practice at the top of your license. So really, you know, including new skills and continuing to learn and to become an expert in something new and something different. So I have worked on the Hep C ECHO for a really long time, and we have providers who are known in their office for being the person that treats Hep C. So they get patient referrals just for that. So it's really a neat model. And so we're going to move over and talk about our COVID-19 response ECHO, but I just want to say, you know, it's so exciting and I think fortunate that we're able to do this because that we've been able to establish this ECHO structure in the state. I can talk from kind of a logistics perspective. We put this ECHO together in a week. When we started with ECHO in 2018, I don't think I could have imagined pulling an ECHO team together in a week. But we did that because we now have all of these connections. We have people that we can tap, like Juan Carlos, who are going to be a fantastic facilitator. They know the ins and outs of ECHO and can make this happen really, really fast. So we're able to be responsive and innovative and hopefully, you know, play our part in the response to COVID-19. So Juan Carlos, I'm going to pass things off to you.
Yeah, so this is just a screenshot of what the gallery view looks like on an ECHO with over 200 participants. Not everyone turns on their cameras, but we do have a fair number of people in engagement and some regular followers that like to contribute and ask questions and share their experiences. A lot of them are from places that are not Indianapolis or the major metro centers in Indiana. Can you go to the next slide? So like was mentioned, we were able to do this through a lot of partnership. A lot of the hub, so you saw in the model, knowledge is coming from folks from these different organizations who are not always strictly in Indianapolis, but have had connections with the academic institution, and several speakers from Eskenazi and some other organizations like the Rural Health Association and the Telemedicine group. So we've been really fortunate, and Becky Sanders has been an important part of that too. We appreciate Becky. Can you go to the next slide? The curriculum, we kind of identified what we thought people wanted to know early on, and that list has been influenced by every time we have a meeting, we are asking, you know, in closing, like what other things people want to know about, or maybe a topic is emerging. So you can see what we talked about early on in this process. We just had week 5's meeting, but we were talking about infection prevention, transitioning to telemedicine. We talked a lot about just the early kind of challenges with PPE that we were all talking about and worried about as the surge started to mount, and what we were going to be doing with testing. It transitioned into talking about medical treatment and the ICU and the emergency department response, triaging patients, and all of the newly investigated therapeutic options. And we've had fortunate, strong connection with Purdue College of Pharmacy and Carol Ott from there, who's been able to share some great updates. And then last week we had it was more of an emotional discussion about long-term care facilities and the impact that COVID has had on them in Indiana, and hearing from people that work in those settings. And it brought to light this issue of the healthcare providers on the front lines in their mental health and emotional support of each other, and just that resiliency that we are learning to build in light of this big major crisis that's happening. And I think that's kind of led us to think, well, at some point during this, in the next few weeks, we need to talk about our mental health, you know, as much as we talk about the mental health of the patients we're serving, because we need to be prepared to handle the long fallout of this crisis. And today we had a great change of pace, talking about implementing organizational change, talking with the meeting, and website manner for folks conducting telehealth visits. A question just came in from Kathy Moore. Can anyone get the recordings? If you register, you get access to the box. So we have like 500 or 600. If you want to go to the next slide, I think it might show coming up here how many people we've had. It'll show in a second register, but far many more people have registered than are attending live. And the people who have registered will have access to the information at any time, kind of on demand, as well as resources that continue to be added.
Right. So we have kind of just a small level of, I don't know if security is kind of the right word, but by registering for the program, you know, we are able to provide you access to our box file. And that's where we keep all of the recordings, all of the didactic presentations, and then additionally resources that come up during the discussions. So we've had lots of people who are able to share, you know, this is something that I'm using in my practice. We have a medical librarian who's able to provide emerging literature and things like that. So it's a pretty nice little resource hub of tools and such.
Do you mind, Andrea, posting the link to join the COVID-19 Echo in the chat box?
Yeah, I can do that.
If it's a lot on your end with the screen sharing, let me know. But I was just gonna say here that these are some of the topics that have emerged as important. There was a discussion of, you know, what resources are available to caring for people experiencing homelessness here in Indianapolis, but we got to learn from some of our participants what they're doing in other places, like in South Bend or other places in Indiana, with some of those particular issues that maybe the people on the hub side aren't as familiar with, because we're operating in our closed bubble of the more metropolitan areas. You know, we got great questions from rural health entities about how to handle things on their end when it came to resource allocation and processes. So if you go to the next slide, Andrea, I think this kind of shows who's been participating. We said almost 700 registrants.
I think we got one more this morning, so we can officially say 700.
Yeah, from multiple states, you know, regularly having over 200 attending live. We have people from all areas. And that's what most echoes tend to be. It's not all just physicians or non-physician prescribing, like PAs and NPs. It's everyone. So it's a really great model, and it really helps, I think, it's all build each other to the top of our license. Next slide.
So this is just a map of all of those 700 people. So you can kind of see the spread. We have lots in Indianapolis, but really all across the state. And then, as we said, people are joining from all over the country. And as you can see, like Puerto Rico and other stuff. So the word has gotten out. I don't even know how it got that far, but it did.
If we want to go, just to use, I don't want to go over our time. So I want to try to practice a model here in a second. These are the fun little, it's always nice to hear appreciation on our end, because we don't always know, you know, like, how are people receiving this? And some great things like, I appreciate it, I'm enjoying this, they've been beneficial. Someone shared some appreciation earlier in the chat box today. It's kind of good to understand the overall situation. I'm finding a lot of information from my team. I mean, there's a lot of information out there. We're all getting bombarded with information. I'm sure you get like 20 emails a day minimally about this, and updates from day to day. The nice thing about this is it's a venue for collaboration, interactive discussion, and ongoing support from, you know, just who are the local experts or the people in your community that are the ones doing this at the state, at like maybe at the hub site, but also just broadly around the state. You get to know names, and it's a networking opportunity. So it's a little different than your typical webinar of just, oh, let's sign on and hear what the state update is on how we're handling the COVID-19 epidemic or pandemic. This is different. So we're going to do a little mock echo here just for the 5 minutes. I just want to show you how this can be interactive, because I got an interesting patient case myself yesterday, and it might sound like something that could happen actually in any healthcare setting. The important thing is there's no protected health information shared. We don't share any information that could potentially identify that would include like geographical location, where they work, or something like that. So we'll go to the next slide. So this is my patient case. You could imagine this would be a patient that maybe came back to us in our community setting from being at a higher level of care where they were in an intensive care unit as a result of being found actually minimally responsive at home with a SAT in like the 50s, and brought to the emergency room, intubated and in the ICU for about 12 days. So this is my patient, 63-year-old Mexican man. He has no health insurance. He works part-time in a restaurant. He normally, as I knew, he only had hypertension, chronic rhinitis. He's on a statin, has benign prostatic hyperplasia and hypertrophy. And he is, he was hospitalized for acute hypoxemic respiratory failure. He was found to be COVID positive. They didn't know that when he was admitted. Didn't have any known exposures. He was on the ventilator for 8 days. He was treated with these medicines that I'm not very familiar with using myself, hydroxychloroquine more so, but tocilizumab. That's hard to say, and I don't think I said it right. And he was diagnosed with a secondary Pseudomonas pneumonia, or that's what I was eventually diagnosed with. And he was started on empiric antibiotic treatment while in the ICU for this. He was found to have an elevated D-dimer, which is a marker potentially showing that he could be at risk for clots. They treated him with anticoagulation in the hospital and actually sent him home with a prescription. At the time that I found out that he was hospitalized in a different healthcare system. His wife walked into the office and said they weren't able to pick up the prescription for the Eliquis he was prescribed, leaving the hospital. And I had no discharge summary or record of the hospitalization available. I had like a visit summary that they were given at the hospital that didn't have any useful information to me other than a number that I called and got a voicemail to try to reach the hospitalist service at the admitting hospital and discharging hospital. You can see his current medications. And so normally what I do at this point is I might spend a little bit more time on the presentation. I'm kind of rushing through here, but I would throw it out to you all to ask any clarifying questions. So if anyone wants to just unmute themselves and ask me any clarifying questions, I literally got this patient information yesterday.
And kind of what we mean about clarifying questions is just like, what else would you need to know to be able to kind of start to make recommendations or decisions about how you would approach this patient? So, you know,
not getting too much in the nitty gritty of the medical details, because that's still like a lot there's a lot of uncertainty. But what are some of the questions you would want to ask? Because my big question from this is, how can I improve the discharge outcomes for this patient? Like, I want him to not be readmitted. I want to reduce any morbidity or mortality from this COVID infection that he had in hospitalization. Do you have any clarifying questions for me about, you know, information you'd need to be able to give me recommendations on this?
We like cricket silence and echo. We're comfortable being silent.
It gives time for people to unmute themselves and ask a question. Any questions?
And if anybody would like to chat anything.
Don, were you going to ask something?
I was just going to ask, maybe I missed it. Was there any case management from the hospital or follow up with a case management agency, like an area agency on aging?
That's a great question. I don't believe there was. I did not gather that from the discharge summary. I didn't mention that I eventually got down the discharge summary. There was our health records do talk, but there was a discrepancy in the patient demographics on the other hospital side. So we had to, my nurse is an expert, and she found out how you could find through this Care Everywhere feature on Epic, how to retrieve the record from the other hospital. But I read the discharge summary and I didn't see anything like that. And it's something that I've seen done at my hospital that we've been doing with COVID admissions. So that surprised me.
All right, Juan Carlos, you got some questions.
Yeah, I
Did
see
the
them.
patient receive information in their primary language? I'll shoot them to you.
This makes me so upset. I'm bilingual myself. I take care of a large number of Spanish-speaking patients. The progress note said no dolor, no fiebre. Like the attending knew how to ask those two questions, and the patient said no and didn't have any other conversation. There was no documentation that information or education was given in the patient's primary spoken language. So that disappointed me.
And does he speak English?
He could get by with some minor stuff, but he's primarily Spanish speaking, and that's how he prefers his medical care.
Great.
And
what about any eligibility for assistance such as Medicaid or other social services?
That's great. Well, in our clinic, we have access to those things. So if I had been communicated with, I could have been proactive and probably jumped on the gun a little bit more, but I'm already using my resources now. We're 2 days out from the discharge date, and we're assembling our resources now. And that includes some social work assistance because we're a federally qualified health center and can offer some of those out wraparound. And the hospital, I don't think you use a translator. I'm getting a great questions. So you can see how this model can be used. Now, we haven't done a case presentation with ECHO, but with COVID-19 yet, because we have more than 200 participants, but we're thinking about how we could do that. The question about the type 2 diabetes, there was nothing in the discharge summary about the A1C that they got at the hospital that was 6.6. Prior to this patient's wife has diabetes and is living with diabetes. He has always had prediabetes, and I check it annually. And so this is a new diagnosis, and it hasn't been addressed. It wasn't addressed in the discharge. The admission history just said unknown past medical history. They didn't take any effort to speak with his family about his medical history or to get in touch with me. So someone's sharing.
We're at time, Juan Carlos.
Yes.
I want to be respectful.
That's good.
But,
so
yeah.
The point is we would talk about the answer, how we could improve this. I've already gotten at suggesting things that I've been thinking about and you all are thinking about. And so I just appreciate that. The last person even shared some of their experience and that they have a long recovery. When I talked to this patient on the phone, they did not sound very good. We have a phone visit this afternoon, so I'm going to check in with them again. But yeah, thanks. So that was our point, to be a little interactive at the end and show you this model in practice. And thanks so much.
Hey,
Thank
this is Madeline from the Indiana Hospital Association. Just one more quick question. I've been waiting patiently. Looking at the medications from the care the patient received on the acute care side, looks like they were on the hydroxychloroquine and the T medication, which is also kind of a newer arthritis medication, so to speak. Do those medications carry over into post-acute care? I mean, I know a lot of it is still under investigation and they're learning a lot more of the do's and don'ts, especially with the hydroxychloroquine, but are those medications continuing over once the patient is discharged?
I'm glad you asked that. These prescriptions weren't continued. There's been some more updates in the evidence about hydroxychloroquine. And the other medication, I think, is still being investigated. Next week on ECHO, on Wednesday morning at 8 a.m., we'll have an update on pharmacologic therapeutics for ECHO and for COVID-19 and the ongoing investigations. This patient, the only medicine they were continued on as an outpatient was the remainder of their antibiotic treatment for their secondary pneumonia, as well as the Eliquis. And there's not even a lot of evidence on that. But we're going to talk about that next week on our ECHO on COVID-19. So thanks for asking that question. And if you have questions afterwards, I'm putting my email in the chat box because we do need to let you all move on, but you can email me any questions, okay?
And it's fine if you want to take a little more time.
Yeah.
I don't believe Becky Hancock has been able to join.
Becky has joined us, Becky.
Oh, okay. I didn't see her name. So I see her face now. So, okay. Well, thank you. Go ahead, Shelby.
Awesome. Thank you so much. And thank you to Juan Carlos and Andrea. It was a wonderful presentation. And yes, I'm sure questions will come through. And I see Juan Carlos put his email in there. So we'll definitely make sure emails do go out in our follow-up as well. But Becky Hancock, I know we have a lot of Beckys here. So Becky Hancock, I want to give you a moment to share your screen and your slides. But I have the great pleasure of working with Becky at the Indiana Hospital Association. She's one of our patient safety and quality advisors, and she specializes in sepsis and healthcare quality. And many of you know, she actually just completed her PhD as well, a qualitative analysis for older adults' experiences with sepsis. So she has a lot of information to share, and I definitely want to give her plenty of time to share. So with that, Becky, the floor is all yours.
All right, thank you. Thanks, Shelby. And I don't have access to the chat right now as I'm doing the presentation, so please interrupt me. I do want to thank everyone for the care that they're providing during this COVID pandemic. I think we're handling our hospital care very well from what I'm hearing, and I just complete thank you for that. I also want to just mention that we're working hard behind the scenes for you, and please let us know anything more from the Hospital Association that we can do. I was asked in 30 minutes to identify these sepsis risk factors and SEERS criteria for screening and COVID-19 screening, and a little differentiation of that. I'm going to share the Indiana State Sepsis Survey results on screening with some recommendations from the hospitals about what was going well as challenges, so you can see if you fall in or out of any of these categories, and try to adapt some of these recommendations to your own complex organizations. Every organization is different, and adapting other hospitals' procedures to your own takes some creativity, but it can be done. And then identify these improvement strategies for sepsis screening and identification based on the State Sepsis Survey and what we're seeing across the state. Risk factors for sepsis first. So I'm going to go through a little bit of COVID and versus sepsis, and then I'm going to go more into our state survey and then touch on a few things at the end. The history taking of these patients is so very important, especially in sepsis, and as we're seeing in COVID, for exposure for COVID, but also for previous events that may be creating a suspected new or worsening infection, and the risk factors that are present. As you can see, there's some commonality between COVID and sepsis and the risk factors, which are not unusual things. We know each of these risk factors, such as diabetes, renal failure, age, and as we're finding out, race in many of these categories, are affected in the way that we diagnose. So keep these in mind. We're seeing a little more renal failure, an issue for sepsis, whereas liver disease is the issue for COVID. And COVID specifically is a respiratory event, more so than the general other sources of sepsis. So keep that in mind as you're doing your assessment. But each of these are very important to understand what the patient's capacity is. And I put the pictures in there just a reminder of how important the history-taking process is, especially in sepsis. I mentioned the recent UTI, pneumonia, or operative event, and diagnosing whether or not that was present or not is a tricky thing, especially in older adults. So you have to be an investigator and really think about the patient's overall risk factors, including age. I put some hyperlinks in here for you to take a look at, just to make sure, not having been a part of these conversations before within this group, but CDC clinical guidelines and management for the surge, and that 81% fall in the mild to moderate category. Many of these are not hospitalized, 14% into severe categories, and 5% into the critical category. So we know that not all patients are hospitalized, and that is data from China, but you can reach the hyperlink there. But again, it's a large variation in the outcome for these patients. I saw in the chat Gloria Barth's comment about the need for patients at discharge for home health care. What we found in readmission reductions program was they really needed that call 24 to 48 hours after they got home. If they'd refused health care at discharge, it was really important to reassess that, because they got home and they realized they needed more care than what they anticipated and were not coping as well as they thought. So thank you, Gloria, for mentioning that, and home health care needs at discharge. When to seek medical attention, I just want to put this resource in here from the CDC for patients. For example, if they come in through the ED and they're assessed and they're sent home, make sure that they're getting discharge instructions about when to return for care. It is easily accessible from the CDC. To fall back into sepsis specifically, our most common sources of sepsis are mostly bacterial. Coronavirus is a virus, so the way those are treated are very different. But when you think about the sources of sepsis, and I'll focus on an adult and older adult because there's a whole different line of thinking for pediatrics, but there are some new recently published pediatric guidelines that I've got in a hyperlink coming up. But when you think about the common source of sepsis, number one for all adults is respiratory, and for older adults, urinary tract infections are number one, and respiratory is number two. So as you're doing your investigative work, don't also forget about the small percentages at the bottom of the adult around skin, wound, and catheter infections. A lot of the events are from post-operative events, and so wounds, catheters that may be remaining, as well as skin issues from skin ulcers. I think these are oftentimes missed, and that's a generalization there, but we know that those turn into incredible reports that should have been handled a little different. So keep in mind when you're assessing, these are the areas that you should be assessing for the presence of infection. Now, we do know that 22% of the sources are unknown for as far as the source and where it came from. And some of those could be viral as well, and you can't find out where that viral source is, but coronavirus is an example. However, coronavirus patients are not prone to the same type of bacterial sepsis outcomes as are general sepsis patients. The coronavirus patients are respiratory in nature and ARDS, and that doesn't equate to getting sepsis. And it's also viral in nature. So the whole sepsis treatment algorithm is not going to directly apply to the COVID patients. I pulled
Becky,
a few. Yes.
We did have a question come in, and this might be a good time to answer it. The question is, has there been any correlation with COVID patients who have previously received the pneumonia vaccine? Wondering if this vaccine seems to provide any protection from developing a more severe case of COVID-19.
I have not seen any data related to that. I think if you maybe looked at permeation of our pneumonia vaccines, our patients, because we're still checking, I'm sure, for all the patients who came in, you could see which ones did and didn't have it. And of course, we don't have any more than a month of data in. IUPUI would probably be the first source for that, looking at it, but I'm not aware of any reporting on that. But again, this is a different virus that probably is not included in the pneumonia vaccine, so it's probably not going to be relatable. That answer your question?
Thank you.
Sure.
Yes, thank you.
Sure. I pulled in a few slides from my dissertation because what I wanted to point out here is sources of sepsis. You know, I did just 25 patients' evaluations of their causes of sepsis in older adults. It was a small analysis, but what I found was the most common was a post-operative event, including spinal, uterine, hernia, prostate, and dialysis shunts. Those were the events, but the most predominant was a post-operative event from which they developed sepsis. So in our discharge education from the hospital, we need to make sure with our surgery patients that they're getting that. Even if they're outpatients, they need to be aware of the signs and symptoms that sepsis may occur and to come back and get treated for that. The rest of them are the same as what we saw on the previous slide. But in this small sample with older adults, post-operative events were striking. And when they're talking about abdominal blockages and infections in their surgeries, in their events that they had, these patients described agonizing and crippling pain in their abdominal area, as opposed to the caregivers who would describe bad pain. The patients were having severe pain, but the patients described as agonizing and crippling. So two different perspectives. And what I was trying to do is make sure we understood the patient's perspective, which is a little bit different and more emotional than that is just in the clinical signs and symptoms, and taking a look at how they're responding and how it's evolving in the pre-acute phase. I've included here the COVID-19 guidelines that have evolved over the last few weeks. The first one was from the Society of Critical Care Medicine, and it's care of the critically ill patient with COVID. So that was developed using the sepsis campaign faculty to develop this, and they were very careful to not include a fluid bolus in the recommendations for care. This is easily read. It looks long, but there's a chart in there that has the specific recommendations. After that, the NIH came out with a consensus conference, which the sepsis campaign worked with them to develop this consensus conference. And then lastly, Infectious Disease Society came out with their guidelines. They're very similar, and I understand the previous presentation probably had more details, but I just want to make sure you had these guidelines available. On the right side of this slide is the evaluation for severe sepsis screening tool. Well, this is still SIRS criteria, systemic inflammatory response criteria. And even though when we moved from SEP1 guidelines that came out and were what were implemented for our CMS bundles in 2015, and then SEP3 came out from Society of Critical Care Medicine, and even though they eliminated severe sepsis as a diagnosis category, we still are operating off of the Sears criteria for screening. And one thing I want to mention in here is it's two or more signs and symptoms plus the suggested new or worsening infection. And that, along with the criteria, the signs here that are noted around clinical labs, hypothermia, tachypnea, and altered mental status included in here, that new or suspected new or worsening infection is what triggers a positive tool. And then you go ahead and do your lactic acid and blood cultures and your labs. But I want to mention that every once in a while I'll see this tool come up. It doesn't have mental status on it. I think especially with the geriatrics, we need to include acute mental status changes and someone to know their baseline on that. I did put on this slide the new Critical Care Medicine, Society of Critical Care Medicine PEDS guidelines that came out towards the end of February. I want to say, well, maybe February 17th or so it was presented. So you have that resource there, but that's not my rodeo. And we have a pediatric work group within the state sepsis survey who's done a good job of assessing what the expectations are, and that will be rolled out over the course of the next few months from the state task force on sepsis. Touching on what the state sepsis survey did for us, we had 7-8 different domains here that we looked at, and we had over 80 hospitals reply to demographics, legislative leadership, screening, interventions, metrics that they're following, documentation, follow-up, and education. From that, a little over 50% were rural acute care and critical access hospitals. So I feel like this group was very well represented in the data that we have there compared to 46% urban acute care. So from that, I felt like I was able to get good data out of this for your benefit. When we look at, there are two ways to look at your populations. And I want to emphasize that all you have access to data link, and within data link, Ryan Prentice and Matt Browning have developed some great modules for which you can look at your patients over time and your sepsis mortality, as well as your volumes. So use your data link sepsis app to look at that. But this particularly, there are two ways to look at it. One is based on your DRG, APR DRG 720, which we've tracked for a long time. And you can get down, data showing us right now that we're really down to about a 5% mortality with APR DRG 720. However, when you pull, and that includes primary diagnosis of sepsis, but we pull back and have a broader net and look at all the SEP1 ICD-10 codes, and we can see from that gradual decline in sepsis rate, that's the black line, we've gone from 16% in 2009 down to about 10% in 2018. So we still have room to improve. And what this gets into is the incidence of not present on admission sepsis that we need to continue working diligently on. Within the HIN, we saw that it was kind of flat, our sepsis that was developed during the hospitalization as far as reducing those mortality rates. So this is an area that I want to see us working on is hospital onset sepsis mortality. And that will in turn drive this down even more, because most of what we've been working on so far is ED work for screening, and we need to make sure that we're doing it the screening elsewhere in the hospital. So this is the same graph, but what we put in here is what there were major guidelines that came out in 2013 and major guidelines in late 2015. And as you can see, there's a more of a drop right after those guidelines. We talked about risk factors, and here you can see that in the fatal hospitalizations is dark green and the non-fatal is light green. So in the fatal hospitalizations, the things that were more predominant were COPD, renal failure, congestive heart failure, cancer, and liver disease. Diabetes really wasn't higher incidence in those who died, and that wasn't associated as highly, but these other comorbid conditions were. We also, this is from Holly at this India State Department of Health pulled some of this data out. And this particular one shows the gray dots are United States rates for these different comorbid conditions, and the green is Indiana's rate. So you can see that Indiana had a much higher diabetes rate in the population of patients with sepsis, a much higher COPD, a little higher renal failure, congestive heart failure, and much lower oncology rates. But I will point out that we know that these are some of our conditions that Hoosiers have, are some of which are controllable risk factors. That is a public health issue that we need to continue to work on in order to improve outcomes for our patients.
Becky, I did have a question that came to me. When you talk about cancer, does that include history of cancer?
If it was documented on the, I can't answer that for sure. I think
Okay.
it probably would if it was
That's fair.
documented in the medical history. Overall gaps that we saw with the survey, we pulled out bundle compliance opportunities, but I'm not talking about this time. Leadership engagement, including physicians, that was mentioned a few times, and leadership engagement that they endorse the PI projects, as well as physicians taking leadership. Screening inconsistencies, which is what you asked me here to do today. Inconsistent clinical metrics. With that, we're working on developing improvements within our data link. We have a good application now for looking at our statistics, but I took a list of all the ones that hospitals were looking at to see which one of those we can incorporate within data link so that everyone has access to the same reporting. Community and staff education and standard processes, including provider feedback and sepsis education. Provider feedback loops was extremely highlighted, that made a huge difference in compliance and sepsis education. I'll get to more of that in a moment with screening and other areas. What the facility said was that they had plenty of screening going on in emergency departments, some in the medical inpatient units and some in intensive care units, but this other down here was maternal care was mentioned quite a few times, but 98% of the people are screening the ED, 62% are in surgical inpatient areas. So that's an opportunity there because I mentioned that many are post-operative events, and the medical at 84%. Oncology, not so much, but I think that that's going on. It's just, this is a lot of outpatient areas here that the oncology events are happening in, and intensive care units at 74%. So again, back to surgical opportunities there for screening so that we catch those patients and get them good education. A few of these, 80% screen every adult patient during their initial evaluation in the ED, 20% are not. I think this is an opportunity. Also, 62% of patients are screening every inpatient adult. Ask for a light, I got a light and now it's going out. 62% of hospitals screen every inpatient at least once a shift. And that is, we pulled these screening recommendations from 3 different states, recommendations for the screening processes, as well as some standards from the Hospital Improvement Network. So these lower ones here, 35% are using automated screening and electronic medical record. If you have that as an opportunity, good. If not, there are plenty of paper forms that can be educated and used. As far as identifying that SIRS paper that I showed you at the beginning, but secondly, using a paper tracking form for bundle compliance is really important for those who don't have any MR that supports that. And for those who adopted that paper form to for good communication for inter-unit transfers and hospital transfers, that was valuable. So 62% of the patients response were screening once a shift, with the common units being ICU, medical, and surgical inpatient. So 62% screening once a shift. That's kind of a recommendation of screening once a shift for patients for sepsis. And I know there end up being a number of false negatives and false positives. So it's a really good clinical insight in order to navigate those alerts that came in through the EMR, as well as using good judgment, clinical judgment on your part. What were some of the screening challenges, just so that you know that you're not alone? There's so many ifs, ands, and buts that sepsis, that educating the staff providers is difficult. So being clear and consistent, but also having other people make champions on the units that are the go-to person who really understand this. The ifs, ands, or buts, I believe, are in the educational evolution of knowledge of sepsis. And one hospital, for example, identified a sepsis champion on the unit. So that is the person that you go to for questions. In addition to their clinical leaders, the physicians as well. They were needing pre and post surgical screenings, which I mentioned already, needing improved understanding of sepsis by the bedside nurses. And education involved recommendations were at orientation, as well as annually for sepsis education. Other hospitals began using the stop and watch paper tool as an educational tool. And they had success with using that for educating staff. We need to keep an eye on this patient, red light, green light tool that's being used, and emphasizing that. But again, paper tools matter for communication and education retaining. Some of the other challenges, we know that SEP3, when it came out, recommended using the Q SOFA. This led to confusion by organizations. CMS did not adopt and recommend the Q SOFA tool, and it is simply organ failure assessment. But some insurance companies began denying payment if the Q SOFA was not done. it is a good tool, but it is an indicator of potential mortality in the patients. It is not a diagnostic tool for sepsis. It is an adjunct tool for potential mortality. It was misinterpreted, but nonetheless, we've tried to work with the insurance companies, and it's recommended that a QSOF would be done based on SEP3 guidelines. And it is good practice, but know that it's not a screening tool. It is organ failure assessment, but the labs that you're doing are already indicated of organ failure, but the QSOFA documentation does make it easier for reimbursement. Recognition by nursing staff for the development of severe sepsis that occurs sometime after admission from the ED. Well, SEP3 also eliminates severe sepsis as a diagnosis, even though we still have all the coding available through ICD-10 coding, and it's still happening, but CMS is still using the SEP1 definition, and completion of the required documentation by a provider. This provider documentation, those who are using a standardized order set with having criteria within that allows them to do their abstraction easier, and by following that standardized order set and using that tends to help compliance with the sepsis bundle as is reported through hospital quality hospital compare. A few other challenges: utilization of the resource nurses and educating them, the newer nurses not recognizing sepsis, sensitivity for varied populations and the comorbidities, and I talked about the importance of understanding those associated comorbidities and using your intense history taking for that. Affordably adopted facility-wide process. So we've started in the ED, but we really need to expand that knowledge outside beyond the ED to really make a better impact on sepsis mortality. We know that the nurses are busy, but I think that the impact of better sepsis care and notification and screening will actually improve our ability to care instead of being a nebulous area, being very specific in processes. No designated sepsis coordinator. I mentioned that those who have adopted a sepsis coordinator per unit were valuable, and recognition of sepsis, other comorbidities. So these are the things that we're going to work on as the state. Lack of informed ED physicians. There has been a little resistance there, but again, using our leadership and our champions where we can with a standardized process. I put this slide in here about time zero because there was a lot of variation within time zero documentation identification. Some were talking about identifying time zero retrospectively during the chart abstraction process as opposed to during the clinical care. And in order to meet your 3-hour bundle, you really have to identify time zero at the time when sepsis is diagnosed on the unit. It's a communication piece that we need to meet the 3-hour bundles following this time zero. So, and documentation of that for the purpose of communication using a sepsis flow chart, either that's in the computer or on paper form. Some are using ED arrival is considered time zero, and that sets the standard so that within 3 hours of ED arrival, you're getting your sepsis care initiated using the bundles, and documentation on the worksheet data. I just included all this. You can look through this, and I pulled out just what the high performers were saying, and those are the ones who were performing at 70% or better on their hospital guidelines, sepsis guidelines. In 30 minutes, I don't have time to get all that, but you've got that retrospectively. So the ER screening process has helped with the early identification. This is more of the exemplary work that was pulled out from the high performers. Using the BPAs for sepsis has been noted, and that calls the screening to the RN's attention, whether an inpatient or an ED patient. That works for those who have refined that process from the electronic medical record. The rapid response teams as a part of screening. If a nurse at the bedside has someone to elevate their questions to, and I mentioned the sepsis unit-based coordinator, and this is just general good infection care, but a rapid response team response that if the nurse is unable to get response within 15 minutes, and they have some nursing protocols to implement regarding assessment of labs and fluid access site. Again, Epic I mentioned, still using paper. They felt like that was a success, but overall triage screening schools, sepsis order sets, lactate rounding that some hospitals are doing on all increased lactates across the hospital, doing even if it's remote, you can do screening on those increased lactates to determine if it's evolving into a higher lactate. Overcoming screening barriers. The SIRS criteria for OB patients. I wanted to mention here that we do need to be checking for sepsis in our OB patients because it is under identified, and it's just a missed opportunity. Many of the other units that were reporting that they were doing screening, it came in that they were doing screening on their OB units. These are a little redundant. Adding a procalcitonin level to our initial labs, that was in there. The procalcitonin level actually is the indicator of whether or not there is a bacterial infection present. It is not standardized within the screening criteria for sepsis, but it is more, is it appropriate to start weaning the patient off of their antibiotics if the bacterial procalcitonin levels are not high. There's a really good webinar that we have on our survivesepsis.com website on the use of procalcitonin that I'll refer you to, as well as a number of podcasts around bundle compliance at survivesepsis.com and screening, and including PEDS screening as well as PEDS improvements. Other successes, ER screening process, a little redundant here, but it keeps showing up. Nurses leading the implementation of a screening process and that rapid response that I already mentioned, and a triage screening stool, sepsis order sets. This might be a duplicate slide, but you got it twice probably for a reason. Maybe not for a reason, maybe speed matters. Overall screening recommendations in clinical practice. These are the recommendations that came out of our last hospital work group for the sepsis, state sepsis work group, India State Department of Health sepsis task force. Clinical practice for screening: enhance their EHRs to capture more specific and sensitive criteria for sepsis, and then incorporate protocols or recommendations of care based on these patient-specific sepsis criteria. So continued enhancements to electronic medical record. Two of them, Epic has an enhanced model, Cerner not as much of an enhanced model right now, but again, if you don't have the EHR, there's still the paper forms that are working very well and actually provide good standards of education. Education, help the nurses understand the screening process and when and what needs to be communicated to a provider. And some are using SBAR criteria specifically for sepsis. They've implemented SBARs in some of the long-term care facilities by their education, and being real clear about what criteria needs to be addressed for these patients, so the provider recognizes and hears repetitive sepsis content when they're listening for certain things when they get the calls. I wanted to put in here which of the guidelines elements bundles were so difficult to attain for the hospitals, and primarily the highest one is administering the required fluid bolus, and second is measuring repeat lactate levels, and third was identifying time zero. So those are three things that I tried to hit on here. Measuring repeat lactate levels, I have some recommendations on that too, based on the survey if you're interested in that. Overcoming bundle obstacles. I want to just point out two down here: doing a deep dive into your data and keeping a track of all your failures within the sepsis bundle compliance area, and educated around those, and using your order sets. Lastly here, having sepsis champions that provide real-time training. So when I heard themes coming out, I heard them repetitively, and those are the things that I've tried to mention today. Utilizing lean teams for real-time feedback, a feedback loop on their process monitoring, reporting, and improvement. Not all critical access hospitals are reporting through Hospital Compare, and some who are have very low quantities of patients, so it's blinded in Hospital Compare, so we don't have access to that. There was some conversations about whether all critical access hospitals should be reporting. All critical access hospitals should be documenting and following and tracking bundle compliance in their hospitals, and do performance improvement processes within sepsis care, but specifically, are you meeting your bundles? Now, some of you are going to be transferring your patients. I'm going to skip through these right here, and I want to get to some other, I put some quotes in here, but this is a list of all of the complaints that the patients had when they were coming in based on 3 interviews, and it's a real varied types of complaints that they have, which is why you need to be so so specific with detecting and doing your medical history, but hard to arouse, excessive sleeping, lethargy, fever, of course, but this lethargy, hard to arouse, and excessive sleep. This was 3 nurses that I interviewed, and those are the things that they noticed in their family members who were experiencing sepsis. Self-management strategies. Many of the patients are taking antipyretics as pain medicines at home, and that can mask their fever. We reported that older adults oftentimes do not respond with a fever for multiple reasons, but double check and see if they're taking antipyretics, and also if they're on calcium channel blockers, which will prevent them from having an elevated heart rate when they hit the ER. Some of these things can mask symptoms that we're looking for anyway. I treated with the pain and the usual antacids and Tylenol and try to go back to sleep. Of course, there goes your fever that you're looking for. Why didn't anyone at the hospital or any of his doctors tell us that he had or could have sepsis? And mention that a discharge, if they come in through the ED with a potential infection, good education for what they need to come back for. They mentioned in the, this is from my dissertation work, their concerns were for overcoming some of the screening barriers, the hospital services not admitting, and this is caregiver perception, delays in refusing care, inexperienced staff, care omissions and misdiagnosis, and care errors and guidelines. All these things are coming up within your questions of screening, but these are general overviews of areas we can continue to work on. At the second hospital, they started antibiotics 12 hours after she presented to the ED. She never received any of the care described in the guidelines, and this actually occurred after the guidelines were implemented. I pulled a little bit of information about sepsis inter-hospital transfers. 59% of patients in this study were transferred to a larger medical center. And of course, those are going to be your more acute patients, but the mortality was higher of the volume of patients that they were transferred from an inpatient versus the emergency department. So waiting until they're worsening, I'm not going to make a judgment on when that is because this is a clinical judgment call. But again, the mortality is higher if they were transferred when they were sicker. Additional costs, of course, for the patient. They were most likely to have commercial insurance if they were transferred. There's a longer length of stay for the transferred patients, and they also had a higher mortality. Well, the sicker patients are going to be transferred. But what I want you to consider is good communications among the providers, including EMS, and where you stand on the 3 or 6 hour bundle compliance matters in that communication. What were you able to do? What were you not able to do? And using an algorithm for where you are in the process is important.
Becky, there is a question that came in. Are there some best practices for readmission prevention for patients discharged after sepsis diagnosis?
Funny you should ask. My next slides cover that.
Mm-hmm. Okay.
So life after sepsis and prevention of sepsis. At discharge, I mentioned earlier that oftentimes they get home and they don't know that they need more care. But at discharge, the readmissions are very high, up to 40% in 90 days and 25% in 30 days. But among the things that we see as issues are immobility. Mobility improves resistance to infection, and we don't talk about that enough, getting up and moving around. Oral hygiene. I'll get to a couple slides on that in a moment, but hydration. I want to focus on oral rehydration therapy, an article that was shared. We don't have to give IVs to everyone to keep them well hydrated. Oral intake makes a huge difference. Older adults, you get dehydrated, concentrated urine, more likely to grow bacteria, and then you're back in the hospital with a urinary tract infection. All of our older adults and younger adults as well, all of us need to be doing a better job with oral rehydration therapy. It doesn't always have to be an IV. Education about what to expect, medical follow-up within 1 to 3 days. They also may need they're going to experience some anxiety, some PTSD if they were in the hospital, potentially an event. And we've got a really nice podcast on post-ICU care that's available. So adding prevention, hand hygiene, of course, even my 88-year-old dad today, last week on his birthday, said, I can't believe it took me this long to learn how to wash my hands. And it took a crisis like this. And my mom, a nurse, clinical nurse specialist in rehab, I taught you that. Of course, he just didn't hear it until he heard it multiple times over the TV. So hand hygiene, hydration, mobility, immunizations, as we touched on early, and oral hygiene. And I want to mention oral hygiene here for a minute. First, I want to mention population systems-based approaches for prevention, immunization, primary, secondary, and tertiary approaches. This is an article worth looking at, and it came out and said sepsis is a preventable public health problem. And so this applies some to readmissions as well. But immunizations, your hygiene, public awareness, antibiotic prophylaxis, and managing your risk factors, all of which I've touched on today. Getting your sepsis care bundles appropriate. People who got their sepsis care bundles are less likely to be readmitted. Less likely to be readmitted. And right now, our sepsis for the state is running in the 50% average. We're going to lose data from the first 3 quarters of 2020, and we will not necessarily know if some hospitals opted not to report on their bundles, but we have to do better as a state in our sepsis bundle compliance. The range is all the way from up in the 80s down to the teens, and we're working on this. Non-ventilator hospital-acquired pneumonia is an area I just want to finish with. And what they've researched, and this was started out in California by Drs. Quinn and Dr. Baker and Barbara Quinn, nurse researchers. And by giving patients toothbrushes and doing good oral hygiene throughout their hospital stay, they were able to reduce by 70% the non-ventilator hospital-acquired pneumonias that were occurring in hospitals, and it's the major cause of sepsis, pneumonia from their hospitalization. 15 to 31% death rate from this hospital-acquired pneumonia, and that's not ventilator-acquired. This is non-ventilator-acquired. So better oral hygiene, not only in the hospitals, but out in the community. And that also included oral hygiene, teeth brushing, and a mouthwash prior to elective surgery intubation. Big deal, needs to be followed. Follow up to that study they did on this non-ventilator hospital-acquired pneumonia. They did a secondary study, some of the same investigators, but of those patients who developed the non-ventilator hospital-acquired pneumonia, 21% mortality, 36% of them developed sepsis, 36% of them got that pneumonia, and 21% died. So this is a big opportunity for improvement in pneumonia prevention for the non-ventilator patients. We got a lot of data from NHSN on IVACs and ventilator-acquired conditions, but this is your non-ventilator. These are the ones that are going home and coming back for readmissions. Oral hygiene matters on the way out the door, as well as oral rehydration therapy. I've gone a little bit over my time, and I do apologize, but any other questions in the queue? Becky Royer?
No other questions at this time, but please chat those in. I did just receive one question. Was it recommended how many times per day an individual needed to brush their teeth? Like I take it from the question, a recommendation of like a minimal number?
Yes. So Joanne Brooks did a webinar for us back in 2018 on recommendations related to oral hygiene. And if you go on our survivesepsis.com website, go toward the bottom, our 2018 archives. It's an excellent 1 hour. She's even kind of funny, so it's humor matters. But she pulled in the 4 times a day ADA guidelines, the American Dental Association guidelines. So that's after breakfast, lunch, and dinner, and then before bedtime. That is the ADA recommendations. It has not been specified for hospital care, but we also had a presentation in our 2019 series on sepsis about IU, I believe it was IU West's or IU University Hospitals implementation of the program, and they started with just making sure that the supplies were at the bedside, making sure that people were getting their oral hygiene supplies during the hospitalization, and then making sure that it was done. It's also a place that can be charted in the EMR, and you can track it that way, at least as it getting done, and work your way up to getting proficient. So hospitalized,
and
ADA is 4 a day.
Okay. Thank you. Another question is, are there support groups for patients that are discharged with sepsis?
Excellent question again. So one of our podcasts was done by Barbara Kahn, who is a physician and a pulmonologist at Eskenazi. And Dr. Kahn has, and his research group have started a clinic for post-ICU rehabilitation. And while it's not, the whole idea is that we have under-recognized post-ICU psychosis or post-ICU syndrome and associated post-sepsis syndrome. And I'm not aware of any specific support groups. However, survivesepsis.com, or not Survive Sepsis, the Sepsis Alliance, sepsis.org, has a place to do Faces of Sepsis, describe your experience with sepsis. It's rather cathartic for these individuals, either who a caregiver may report as a victim of sepsis or the patient themselves as a survivor of sepsis. And within that, there are groups that have emerged, including there's an advocate in Indiana whose husband died of sepsis, and there's a podcast that she did for us as well, Lisa Bartlett, for her husband died in 2012 of sepsis and left her with kids and everything. But she does a run, an annual color run that's supposed to happen in June, but through that she is looking for people to help with her color run who have been survivors of sepsis as well as caregivers. So not a specific support group, but Dr. Khan is allowing patients to participate in his clinic if you want to get follow-up for rehab. And of course, that's geographic specific. That's in Indianapolis, but it is a research clinic. So some of the patients in the target hospitals are being recruited for the study, but you can also participate if you were not at those target hospitals in his rehab clinic, but not any local sepsis support groups that I'm aware of, unless someone else knows of one. Sepsis Alliance has a lot of support work for caregivers and for patients, and education as well as the best resource.
Thank you. That was helpful. And that's all the questions that I have in the queue right now.
All right, thank you very much. Thank you for the opportunity, and thank you for all the care that you're providing out there. I covered a lot of information, but referring to the slides will be helpful.
Yes, thank you. Okay, I will turn it over now to Don and Shelby if you'll share the questions so that we can do a little bit of networking, but definitely please chat in whatever challenges you're facing right now. This is kind of a time for all of you to interact with one another. So, Don?
Thank you, Becky, and also Becky. So yeah, like you said, Becky, this is just a time for some networking. It's one of the most important times when we're face-to-face, and we're trying to provide that opportunity through this virtual session as well. The email that went out yesterday, we asked you to come prepared to discuss a few questions that we'd come up with, but also, like Becky said, if there's something else that's really you're struggling with or you want to get some feedback on from your peers, this is the time to do that. You can put them in chat, or you can take yourself off mute and speak to us. So the first question that we're kind of starting with as you get warmed up is, what lessons have you identified from the ease of elective surgery restriction at your hospital that would be helpful for others? Or would you like to bounce some ideas off of participants? How many of your, I'm really interested in hearing, if your facility has restarted elective surgeries, what kind of practices are you putting in place?
Hi, can you hear us? This is Deb from Rush.
Yes, Deb, go ahead.
I was just wondering what folks are doing, if I could ask the group, what they're doing about the testing patients for COVID before they actually get their surgeries, because we have a very limited number of swabs available to us. We've ordered more swabs, but that was over a month ago. So I'm kind of being militant about who's getting that opportunity. So I just wondered if everybody else is testing everyone before surgery or not.
This is Andrea. And Beacon Health System is testing everyone prior to surgery, asking to shelter in place between the time of testing and the surgery.
Okay. Thank you, Andrea.
The question we're working on is, what about other areas like the wound clinic and IR, thoracentesis, paracentesis? procedural kind of things. Not always elective, some of those are more emergent. What about testing? And if it's sequential surgeries, how often are you retesting?
Those are great questions, Andrea. Any response out there for those?
Yes, Lori shared that they have restarted elective surgeries this week at Margaret Mary. They are not testing everyone before surgery at this time. And then IU Health is restarting at 25% of usual volume this Monday. Procedures vary by facility. So if anybody would like to unmute and add anything to that, you're more than welcome to.
Hi, this is Jill Green. Can you hear me?
Yes, Joe, go ahead.
Yes.
Okay, we started back some elective surgeries on Monday. We kind of were doing it slowly at first. We are not using, we started with scopes and kind of easing into everything else. We are not testing because like I think Deb said earlier, we don't have enough swabs to test everybody. So we are in-person screening patients about 2 days prior to an off-site clinic with the CRNA. And then whenever they get here the day of surgery, we're screening again. And that's how we're kind of weeding some people out. But our question was how quickly is everyone else looking at endoscopies and dental surgeries?
Those can be potentially higher risk and require different PPE. So what, do we have any responses in the chat from that, Becky, or?
Not at this time.
Okay. Oh. I just saw one pop up that Margaret Mary's starting them next week, starting endoscopies next week. So, Lori, are you putting any different procedures in place for those endoscopies or any special changes as far as compared to your other elective surgeries? And feel free to type it in chat or to hop on the phone. Well, we wait for that. Andrea, did you get the response you were looking for from your questions about the surgeries? I want to make sure we're not jumping past things.
Yeah, we have not had the shortage of swab issues right now, but the force for incident command is really holding to the testing prior to surgical procedure. It's just hard. We're having patients push back with the stay at home. I don't feel that some patients don't feel that they need the test. Some patients don't want to isolate between the time of the test and the time of surgery. So what good is the test? So there's just a lot of area to proceed with.
Sure. Well, I appreciate that. And Lori did respond in the chat that they're in the process of developing those procedures and guidelines now. We don't have those yet. Becky, in the interest of time, I think maybe we should move on to our next question. We can, if someone really does have a burning question or other things that need to share, we can always come back. But all right. So are there any, this one is a little bit more general. Are there any questions or concerns you would like to share or reach out to the other critical access hospitals to obtain input, and really maybe beyond those elective surgery areas?
I think that Andrea earlier brought up a good point. People are still afraid to come to the hospital. how are you reassuring individuals that when they come, every precaution will be taken for their safety?
We have marketing working on that now.
Do you have plans on how to do that? The Facebook, email, reaching out individually to let the community know?
I think though we have a Beacon website. We've tried to put on some YouTube conversations with local physicians and medical directors. Try to have that physician input, that specialty on safety and precautions and everything from why we ask people to wear masks and why our staff is wearing masks as well. Keep everybody safe.
Yeah, this is Vicki at Green, and something we have been using Facebook Live in our community that's really grown. So in our daily Facebook Live updates every day at 4, we've been trying to discuss that and explaining to the community that we have different entrances depending on what you're having done and so forth.
That's great. Early on, we were running into some situations where, patients that were immunocompromised or suppressed, maybe patients coming in for cancer treatments, felt more at risk coming because they were standing in line to go into those single entrances. So is that the type of situations you're talking about?
Yes, correct. Because we have patients that are coming to infusion center for chemotherapy and such, so we have them use different entrances versus people going to the ER, for instance.
Perfect. Okay.
One last question that came was, how are others addressing patients' loneliness in the room?
That's a great question.
This is Vicki at Green again. Something that we've done is we reached out into our community through the marketing in our foundation and asked for community donations, and we purchased tablets so that the patients can have interaction like we're doing right now, face to face, through tablets and such with their families or with staff. So that's really what we've been trying to do the most of.
We've used tablets and cell phones, kids and families as well as Raymond, and because we're all on one window visit.
Yeah, hi.
We've identified the room numbers from the outside and had families call ahead, so we made sure we could close lines in other rooms, and so that there wasn't, contact with other patients that may not want that, but families have appreciated that. We've been able to do that.
Thank you, Andrea. I heard another voice out there as well.
Yeah, this is IU Health White Memorial Hospital, Mary Manier. Hello, everyone. And we also, we obtained laptops and then attached those basically to overnight bed stands and did FaceTime and went in and spent the time, a team member went in with the patient to make sure that they were all set up and connected. And they seem to really, really respond and really appreciate that and those efforts. Another thing that we did, which probably across the state, I've seen a lot of different people's Facebook pages and morale boosters where we actually did painting on the patient windows of sunbursts and rainbows and hearts and things like that to kind of uplift their spirits. So I think that and just that interaction, that personal interaction, family members seemed very thankful, and so did the patients. And that was basically something, I think, because of my involvement with team members across our system, that's something I've seen within our system pretty much statewide. So probably followed suit with many others.
Thank you, Mary. That's great. I did hear from one hospital in southern Indiana that they had some staff that would have been furloughed, but they've kind of transitioned them into becoming patient advocates for different units, and so that they're going around and just helping them sometimes with those technology and making the connections with family to take that burden off of the nursing staff and the unit staff. That's one.
Or just sitting down with them, having a conversation, or holding their hands.
Right.
Yeah.
Yeah, absolutely. We all need that sometime.
Very true.
And also that it's demoralizing. It's hard, not only for those patients, that loneliness, but for the staff at our hospitals and our facilities, seeing those patients without the family support and the loneliness that they're experiencing. There's psychological effects on our staff as well. Maybe that's the question. Are you doing anything for your staff to help them identify, emotional, behavioral issues that they might be having as they're dealing with either those loneliness issues or just maybe seeing patients with higher acuity and worse outcomes or general anxiety?
Don, this is Becky, and Gloria Barth at Harris, and she and I were communicating the other day, and she has been interviewing patients that were discharged with COVID, just kind of some post-touch points. And something that did surface from one of her interviews was the important role even that housekeeping played in communicating with patients when they're in their rooms. And patients found, that the housekeeping staff, would take some time while they were in there cleaning to talk with them, and what an important role they can play now in the patient experience during this time where patients are a little more isolated. And so I think sharing with the housekeeping staff just how important they are right now in just that patient feeling safe, I think has really, really heightened itself. So.
Perfect. Well, Becky, I see we're right at 12:30, so not sure if it's fun to keep going, or I know some people will probably need to drop off to attend other meetings.
Yeah. We'll go ahead and end for today. Oh, go ahead.
I just want to mention as a follow-up to please communicate with me if you have any needs related to sepsis or expectations that you think would be valuable. And the best reference tool is our 2019 sepsis toolkit that's on survivesepsis.com, because a lot of the clinical tools that I was referring to are in that toolkit.
And we will send many of these links out that had been mentioned today when we send out the webinar recording and the presentations for today. And so we'll wrap things up, and we just want to thank everyone. If you have concerns that you would like for us to reach out to others and get some ideas for you, why, please feel free to do that, and always glad to help facilitate. So everyone stay safe and stay in touch. And thank you so much. Bye-bye.